Chamber programme sound. This is the Northern Ireland.
Good morning, members, and thank you for your attendance at this morning's committee meeting. I declare the meeting open to the public online, and I would like to welcome all of those members who are participating by video conferencing today. Can I also remind members about the protocols regarding the use of electronic devices? In terms of apologies, members, we are aware that Pam Cameron and Jonathan will be late to the meeting this morning. Are members aware of any other apologies?
Orleah has an appointment. She's going to try and get up.
Okay, we'll keep an eye on that. Thank you. Moving on then to Chair's business. Couple of issues I want to mention to flag up. The first one is the fact that this is from the 5th to the 11th of September is Migraine Awareness Week. And an issue actually that impacts women much more disproportionately, but can be, I suppose, and anybody who knows anyone who suffers from migraine, can be very debilitating. I was surprised as a result of the information pack that was sent through to find that 270,000 people here in the north suffer from it, and that's a huge amount of people suffering quite a lot of pain and distress. So I just want to acknowledge that. It's also the month of September is Blood Cancer Awareness Month, and again that's something that impacts many of our population, and we all know around the difficulties around cancer generally and particularly at the present time. So just to acknowledge that and to indicate there's been a call this week by Macmillan around cancer specialist nurses and that, and I think there's a huge amount to be done in relation to how we support and treat and care for people with a range of conditions, but cancer in particular can bring its own challenges. The other two things briefly that I want to mention is I attended a roundtable that was on yesterday around HPV, and again another cancer that's causing some concern, and around the potential for better and more screening that would help individuals and also help the health service in terms of identifying some of these cancers earlier and improving treatment options. And finally, I had done a meeting earlier this week with a number of organisations around a campaign for a TRIPS waiver on vaccines, Oxfam and Amnesty and a few of those, and essentially calling for equity in vaccines in a global sense, based on fairness and equity, but also based on the fact that if there's not a well-managed rollout of this as a global pandemic, if there's not a managed global response, then you create difficulties along the lines of variance and unfairness. So I just wanted to note that. I also want to inform members that we are looking at a potential joint meeting with the Education Committee sometime in the near future, and the clerk is working on arrangements and agenda and things like that for that meeting, but we'll keep you informed as we go through that process. Okay, thank you, members. And moving on then to draft minutes. There are 3 sets of minutes then to agree at this meeting. First of all, I refer members to the draft minutes of the meeting of the 8th of July at tab 3.1. Tab 3.1 there, so are members content with those minutes? Yeah. Members content, thank you. The second set of minutes then are from the meeting of 29th of July, and those are tab 3.2. Are members content with those?
Great. Yeah,
thank you. And thirdly and finally, in terms of minutes, I refer members to the draft minutes of the meeting on 19th of August, which are at tab 3.3. Are members content with those?
Sure, content with the minutes, but can I raise something just that was briefly discussed at that meeting on the 19th?
Yeah, go ahead, Jerry.
Yeah, so I raised with Charlotte McCardle the issue of the NHS pay offer for health workers, which obviously is below inflation, and I think it's quite an offensive offer for many health workers, and I think the committee should take a position to oppose that offer. So I wasn't able to propose it at the meeting, but I want to suggest that this committee writes to the Minister raising our objection to that pay offer, because in real terms it's a pay cut. It's below what health workers deserve and are demanding. So I wasn't able to make it at that meeting, but I want to propose that the committee does that.
Well, I think that would be better put for committee members to consider. I think that's a bit a major issue, and an issue I think that we all have concerns with. But I think, Jerry, if that gets tabled for discussion next week, it'll give members an opportunity to decide how they want to progress that. So if you can hand for that to go.
Yeah, there's no obviously AOB this week because of the time pressure. So I mean, we're able to allocate some time next week to discuss this issue.
Okay. Yeah.
Okay.
Okay. Members content with that?
Yeah.
Yep.
Sure. Can I raise another issue? It was in the minutes, and I know Jerry raised it the last time, and I've been raising it before. And there is correspondence regarding the inquiry into neurology. I do think we need to get a more updated briefing from the department on this. Now, even though there's something in from the inquiry itself, it's still ongoing. But what is happening, when it's happening, how many recalls there are, and what the support is. Because I've met with some of the families, and the distress that they're still going through is palpable. And I don't think anyone in this committee would sit easy having talked to some of those families, as I know most have. So I would like for maybe to be flagged up now but brought forward to the next committee. I appreciate we've a lot on, but we definitely need to get a proper update on what's happening, because there are still recalls and there are still issues around the Dr. Watt either going in front of committee or not, and the delays that's caused because he has a right to respond, and the impact that that's having on people is absolutely disgraceful.
Okay. So are members content to seek more, maybe seek an update from the inquiry and look at when we could schedule a meeting? But I think we should certainly look at a written update as soon as possible to try to get.
Thank you.
Yeah. Members content with that? Yes, Paula?
Thank you, Chair. I'm not sure what's going to be happening today with the recall at 12 and stuff, and I was looking at the pack and I couldn't see when the Minister is next due to come before committee. I'm very concerned that we seem to be easing restrictions and the figures are still stubbornly high, and the daily death rates are very, very sad. So I would really appreciate if we could have the Health Minister and the CMO before Health Committee as soon as possible to tell us what the current policy and strategy is for bringing these figures down. We're hearing small things around vaccines and pop-up clinics and the educational institutions and stuff, but I think that I would appreciate a wider briefing on what is the current strategy for dealing with this pandemic. Thank you.
Yeah, thank you, Paula. And I'll just check with Clerk what the plans are in relation to the briefings.
Certainly, thanks, Chair. We did request a briefing from the Minister at some point over the next number of weeks. That was sent through following last week's session. So the Department have come back to say the soonest opportunity to brief the committee is the 30th of September. So that's the date that we've been given by the Department for the Minister and the CMO to come and brief the committee.
Okay. Yeah, and I have to say that clearly the situation is very difficult. There's no question about that. And once again, urge people to, within the restrictions that are there at present, to look after them, to be as careful as they can, because there's a lot of transmission at the present time. Go ahead, Alan.
Thank you, Mr. Chairman. I think we have to appreciate, Mr. Chairman, that the current move on restrictions are being led by the Executive, not by the Minister of Health. The Minister of Health advises the Executive, and the Executive make the decisions. So I think if we're going to question anybody about concerns that we have over the pace of the restrictions been lifted, and I would accept I would have concerns as well at the moment. But I think those concerns have to be directed towards the Executive, and I think if we're going to ask for any questions, I think we should be directing those questions towards the Executive Office and inviting somebody from there to come and speak to the committee.
Carol?
Chair?
Yeah, I have Carol, and then Paula, I'll come back to you in a second. I have Carol, and then I'll come back to you, Paula.
So I appreciate Alan's position, but as someone who sat on the Executive, we followed, and the Executive is still faithful to this advice given by the Minister for Health, by the CMO and by the CSA. So there's no way around that. I mean, the Executive have some great officials, the Executive Office, who work with that team, Karen Pearson and that. I have no objections to people like Karen going, but I mean, at the end of the day, all ministers and all departments follow advice given by the Minister for Health. So I would ask that it's the Department for Health and the senior officials.
Yeah. So I'm going, Alan. I'm going first of all to Paula, and then I'll come back to you. Go ahead, Paula.
Thank you, Chair. Well, first of all, to the Clerk, thanks for the update on the 30th of September. The past few sessions we've had with the Health Minister, as you know, have been very, very tight. And I think that we've all been left frustrated that we have had questions in front of us, especially from constituents, that we haven't got to. So I would urge that we have a long session, because we haven't had the Minister in front of us for many months now. And just to address the point from Alan, this is not a criticism of the Health Minister. This is us as the Health Committee scrutinising the work of that department. We are still in a very precarious situation. We're heading into the winter months. This is not a criticism of your UUP Minister. This is for us to provide to deliver our role as Health Committee members to make sure that we are on top of this and asking the pertinent questions that our constituents are raising with us. Thank you, Chair.
Thank you, Paula. And Alan?
Well, not for 1 minute what I think that Paula was attacking the Ulster Unionist Party Health Minister, but the reality is that these decisions, and whether you like it or not, no matter what Carl says, that I don't know how she knows what goes on at the executive meetings. I don't know what goes on, but maybe when she was a minister, she slavishly followed the line and didn't question things. But I would imagine that anything that the Health Minister brings forward to the Executive at the current time is scrutinised. I'd like to think it was scrutinised, and I would like to think that a consensus was arrived at, and if changes needed to be made to the advice, then so be it. But we do hear mixed messages coming out when various spokesmen come out. The First Minister comes out and says what's happened in an executive meeting, and then you hear somebody else from the executive saying something slightly different, you know. So I'm not really convinced that ministers slavishly follow the advice of the Health Minister on every occasion, and I don't think the Health Minister maybe gets what he wants, or his chief advisors get what they want every time. That's the nature of democracy, and that's the nature of how the executive, I presume, works. So, you know, at the end of the day, we can query the Health Minister what advice he's given. I have no difficulty with that. But if you want to find out what the thinking of the executive is, who finally make all the decisions, then you need to ask them some questions.
Okay, well, I have to say that our duty and our job and our statutory role is to scrutinise the Department of Health and the Minister of Health. If the Minister of Health feels that the Executive has ignored or has gone against his advice, I would expect him to be coming to this committee before the 30th of September to alert us that that's the case, or to be saying that that's the case. So my understanding is, and I think Carol clearly indicated that she was referring to when she was on the Executive and her experience, but my understanding is, and we have a very full schedule in terms of scrutinising and holding to account the Department of Health. We have quite a full role in that. I have no objection talking to executive, and we have spoke to executive officials, but our principle and our core duty is to scrutinise the department, and the Minister is quite welcome to elaborate in this committee if he feels that his advice is not being followed. But it's my understanding that that is the case, and that the Executive act upon the Chief Medical Officer and the Chief Scientific Advisor's advice. I'll just give Carol a final one, and then we need to move on.
Chair, I think you've covered it. I mean, and Paula's point is the most pertinent as well. This is a health committee. We scrutinise the Minister for Health. Other officials from TO, I'm sure, will accompany. This isn't party political. It would be slightly strange, given the summer recess, that we didn't ask to speak to the Minister for Health and senior officials, and I'll just leave it at that. I just think some of Alan's comments are just disappointing, but listen, that's politics.
Yeah. And my understanding is, Alan, and just for clarity, that the committee, there isn't agreement that the committee feel that we should speak at the earliest opportunity to the Minister of Health in relation to current restrictions. So I think members are agreed with that. Yep. Okay, thank you, members. So we're going then to our first substantive. There are no other matters arising from the minutes, and then we are moving into item 5, which is our first substantive briefing this morning, and it's in relation to the Health and Social Care Bill. So I refer members to a copy of the bill and the EFM at tabs 5.1 to 5.2 of your pack, and also to the departmental response to the committee's request for amendments to the bill and seeking clarification on a number of issues, which is at tab 5.3. I can advise members that departmental officials are here today to further discuss the issues with the committee, So I would now like to welcome by video link Miss Martina Moore, who's Director of Organisational Change. Good morning, Martina. Can you hear us okay?
Good morning, Chair. I can, thanks.
Thank you. Vincent Ramirez, and Vincent is involved in the Organisational Change Directorate. Can you hear us, Vincent? We're not hearing from you there, Vincent. I just check. I think you are hearing us, but we didn't hear you. You appear to be on mute, Vincent. So listen, we'll come back to you in any case, and but you do appear to be on mute at the moment. And thirdly and finally, from the department, Alan Chapman, also in the Organisational Change Directorate. Good morning, Alan, and are you able to hear us okay?
Good morning, Chair. Yes, I can hear you.
Yeah, thank you. I'll just check back very quickly, Vincent. Can you hear us? No, we're still not hearing you. But anyway, Vincent, we will proceed to the briefing, and hopefully that sound issue on your end can be resolved. Okay, members, so I'm going to go back to Martina. I'd like to welcome all three to the meeting here and thank all three for coming to the meeting. I'll go back to you, Martina, and is it yourself that's going to lead the briefing, and then we'll go into members' questions? Am I correct in that?
Chair, actually, Alan's going to lead the briefing today. Unfortunately, I have a few connection problems, so just to make sure you get a full briefing, Alan was going to take you through that.
Okay, yeah, that's no problem at all. So, Alan, over to you then, if you could go ahead and present us with your briefing.
Thank you, Chair and members, and thanks for the opportunity to be here today. I'm aware that the committee recently wrote to the department and raised some queries on the proposed future planning model in the context of the Health and Social Care Bill. I know Minister wrote to you on 22nd of July, which I hope you find useful and will help inform our discussion today. This morning, I'll begin with a brief update on our ongoing targeted consultation on the draft framework of the ongoing work undertaken to date and provide an overview of the response from Minister to your recent correspondence. As you'll be aware, the draft framework is currently undergoing a targeted consultation process, which launched on 19th of July and closes on the 17th of September. The documentation was distributed to a wide range of stakeholders. We have held 2 workshops in order to help raise awareness of the consultation and help improve people's understanding of the development of the model and to encourage formal responses. Early indications suggest that the workshops have been well received. There were over 200 attendees registered across both sessions, and initial feedback has been positive, with the majority of attendees agreeing that the proposed approach to integrated care set out in the draft framework is the right approach to adopt in Northern Ireland. We have received a few formal responses to the consultation already, and from the level of interest and engagement received to date, we hope to receive substantial and useful feedback from across the system and beyond. In addition to the 2 workshops organised by the department, we've also supported and engaged with additional events hosted by other organisations and stakeholders where possible. The responses to the consultation will be collated and analysed in order to further inform discussion and identify any potential changes that may be required to the framework, and a summary response document will be produced and published in due course. Work has also continued to progress in other aspects of the project. Work is ongoing on defining the best approach to provide the ministerial and departmental strategic direction to the model. It will take the shape of a strategic outcomes framework, which will be designed in such a way as to be reflective of the health and wellbeing needs of the population of Northern Ireland. The strategic outcomes framework will consist of a set of high-level outcomes, fully aligned to those of the programme for government and designed on the basis of evidence derived from latest official statistics and complemented with thorough qualitative intelligence from both existing sources and a series of engagement events that are currently being planned. The engagement process, along with findings from the current consultation, will not only provide insight to understanding people's needs and priorities, but also key feedback on how to best capture this local intelligence on a continuous basis once the model is implemented. A work stream has also been established comprising of senior system leaders from across health and social care to consider regional services in the integrated care system. Criteria for regional commissioning of services requirements are being explored, and reasons outlined to date include highly specialised services, small numbers of population requiring service, services delivered by one or more trusts for the region, and services delivered outside Northern Ireland. The direction remains that as the ICS model matures, all services which can be planned and delivered locally should be, and this is foremost in the workstream development process. I will now move on to the key issues raised in your most recent correspondence. In respect of the delivery timeline of a future planning model and when we would anticipate local engagement structures to be put within regulation, it's always important to remain cognizant of the pressures within the system currently as a consequence of the ongoing COVID-19 pandemic and the scale of the task at hand. The development of a fully functioning integrated care system is a complex undertaking and it will take time, and we are only at the beginning of this journey. However, I wish to reassure members that the ICS model is being developed to provide the structure and mechanisms which will ensure that local input and intelligence continues to inform the planning processes. And in fact, the model is seeking to expand that local input in a way that will see it further embedded in how we do things moving forward. To that end, the draft framework sets out that 5 local area integrated partnership boards will be established by the 1st of April 2022. Whilst we include indicative dates within the framework for certain other elements, such as partnership agreements, we'll of course be informed by the feedback from the consultation and ongoing engagement with stakeholders on any specific timelines associated with such aspects. And we acknowledge that what is in place on the 1st of April 2022 is not the end point. Much work will be needed beyond this date to continue to support the model to develop. For example, the model will operate within existing financial and governance arrangements in the first instance, but these are areas which will be further explored over time as we come to identify what the most appropriate approach is for these aspects of the model and as the partnerships mature. It's important to stress that such developments will occur in partnership with those involved in the model. Indeed, we will look to those involved to identify the right solutions for their local areas rather than impose the wrong ones. Moving on to when we would anticipate legislating for the new arrangements, there is no current set timeframe or deadline for this aspect of the model. We believe that it is very important that the model is afforded the time and opportunity to develop and mature before being bound or formalised within specific legislative requirements. Allowing this time ensures any legislative requirements identified as necessary will be the right ones, and the model is not constrained by legislation in the early stages before the right structure, processes and working practices are in place. The lack of specific legislation will not inhibit the ICS model from operating successfully, rather it will maximise the opportunity for flexibility in terms of its development. This is not an uncommon approach and has been adopted elsewhere. For example, in England, legislation is only now being brought forward regarding their ICS model after having been under development for the last 5 years. What is important to reiterate is that the consideration of the future legislative requirements to underpin the model is absolutely part of the development process. In the past, we have had a tendency to legislate first and then implement in line with that legislation, and this has not necessarily provided the outcomes that were desired. In adopting our approach, we believe the model and any future legislation will be much more effective in delivering integrated working within and beyond the HSE system. The committee's recent correspondence also saw consideration of an amendment to the bill that would allow local commissioning groups to continue until the integrated care framework is in place. As I touched on earlier, new arrangements, including the developing ICS model, will come into operation on the 1st of April 2022, and whilst a fully developed ICS model will not be in place at that date, the structures will provide the means to secure local input. They will be in place, and this will ensure that local input and intelligence continues to be an important part of the planning cycle. It's also important that we recognise that there are a number of potential hurdles which would present when attempting to retain LCGs, given such an amendment could not be easily or quickly drafted. In order to retain LCGs beyond the closure of the HSC board would require resources currently working on the development and establishment of the ICS model to be diverted to support the development of any necessary legislative amendments, and this would have a significant impact on the time frame for bringing forward an ICS model in Northern Ireland. A new statutory basis would have to be developed and drafted for inclusion within the bill, given that LCGs are committees constituted under the HSC board. The complexities involved in doing this are unknown at this point and would require careful consideration by the Office of Legislative Counsel and legal advisors, and would entail significant work to settle details of the policy position and give effect to this within the legislation. By way of example, before any amendment to retain LCGs could be taken forward, there are a number of factors for consideration, such as identifying who would have responsibility for LCGs. In each case, the primary legislative duties, powers and responsibilities of any organisation would need to be considered and amended. The type of consultation required and with whom is another factor which would need to be considered, including the impact this could have on the timescales of the passage of the bill. Given the approaching end of the mandate, it's unclear if there is sufficient time to get any additional legislative requirements across the line. And adding to these policy decisions, it is also important to recognise that current members of LCGs have the skills, knowledge and experience that would be sought after for membership and participation in the various levels of the ICS model. We risk diminishing the talent pool available to the ICS model, risk creating confusion around roles and responsibilities, and ultimately risk undermining the successful development and evolution of the model itself. Having the existing structures retained whilst trying to champion and implement the shift to a new way of working would be very challenging. It would be difficult for individuals to give the necessary time and focus to both extend LCGs and commit to the development of the evolving ICS model. We could also inadvertently occur in the push for retaining the existing system and statute. We risk simply replicating the system that we already have and move no further towards improving integration and the way we plan, manage and deliver our services and interventions, and we could in fact create a status quo. The end goal of the ICS model is to expand and give greater weight to the role of local input within the planning process and not reduce or devalue the importance of it in any way. We wish to build on the foundations that the LCGs and others have provided. Overall, the retention of LCGs and statute would pose significant challenges to the development of a new way of working, but importantly, it would also pose a genuine risk to the passage of the bill in this mandate, and therefore a real risk to the proposed closure of the HSE board. Given the significant amount of time, effort and work that has been undertaken to get to this point, and in particular with the HSE board staff in order to provide certainty and clarity on the future and their roles, the department would not be supportive of such an amendment. Moving on to committee oversight, the recent correspondence from the committee had also suggested a possible amendment to the bill which would allow the committee a role in the scrutiny of transitional arrangements. I'd like to take this opportunity to assure members that we are committed to ongoing engagement with the committee throughout this process. It would be our suggestion that an agreed schedule be drawn up for this engagement that would meet the committee's needs, which would hopefully negate any need for specific legislative provision in this regard, but we are of course happy to explore this further at today's session. Moving on to the topic of governance that the committee raised, it is useful to note that the current commissioning processes will largely remain the same on 1st of April 2022, albeit these will reflect the closure of the HSE board. Following the closure of the board, the existing statutory duty for the department to set strategic priorities and objectives will remain, and a coordinated response to these necessary. Whilst the bill will remove the specific requirement for a commissioning plan to be developed by the board, a plan setting out how the strategic priorities and outcomes will be and work is ongoing to review and improve the current process. There will of course be a continued need to monitor outcomes for accountability with part. This work will be undertaken and led by the Strategic Performance and Planning Group within the department, which will comprise of the former board staff. Their skills and experience will not be lost in this process, and they will continue to carry out their duties and functions, albeit under the direction of the department. As noted in previous correspondence and briefings, the groups will be directed by a senior civil servant of the department and will be subject to departmental governance arrangements. And the statutory duty will remain for the department to prepare framework documents which describes the roles and functions of the various health and social care bodies and the systems that govern their relationship with each other and the department. The current HSE framework document, which details these governance arrangements, will be updated to reflect the closure of the board. And all of the HSE bodies remain ultimately accountable to the department and the minister for the discharge of the functions set out in their founding legislation, and the changes introduced by the bill do not detract from that fundamental accountability. Engagement with the Office of Legislative Counsel has advised that the development of a suitable amendment as suggested by the committee to strengthen the governance framework would require clear articulation of the committee's expectations in terms of what you would envisage being required. This would be the starting point in the development process, and following this, the Office of Legislative Counsel would have to be provided with a very detailed proposal about what strengthening governance and accountability across the HSE means if they were to draft any relevant legislative amendments. Only then would we be in a position to fully understand the impact and time required to draft such an amendment. As with the amendment discussed in relation to the retention of LCGs, there's the potential that, depending on the proposed scope of or the complexities involved in drafting, this could put that passage of the bill at risk within the current mandate. The committee have also sought further clarification with regard to production of reports on commissioning and what those reports could contain. As I mentioned earlier, following the closure of the board, the existing duty for the department to set the strategic priorities and objectives will remain. While there will be no statutory requirement for a commissioning plan by the board, a plan setting out how the strategic priorities and outcomes will be, how they will be met, will still be required, and work is ongoing to consider how the current process can be improved. Specific work streams are in place to consider each step of the process, including reporting frequency and the mechanisms which monitor the performance of the system against its delivery of strategic outcomes. The committee had suggested that reports could include information on local engagement and health inequalities, and this suggestion will be taken on board and further explored as part of the development process. Moving on to the last element of your recent correspondence, the committee requested further information on the key differences in the pay scales and terms and conditions that prevent staff from coming into the department. It is very much recognised that current board staff have important skills and knowledge, and that they must be available to support the department in the wider HSE system post-closure. Options for the specific arrangements post-closure were considered and included the hosting model and transfer of board staff into the department. The hosting arrangement, as members have appreciated, provides a practical solution to ensuring the skills and expertise of board staff are retained, and which builds on the close working relationship with the department present. It also enables board staff to retain their existing terms and conditions and supports a more flexible basis for further redistribution of resources as we move forward. And there were a number of mitigating factors against the alternative option of transferring staff into the department. These included clear articulation from board staff that they wish to retain their existing terms and conditions and a desire to continue their careers within the HSC. The option increased the potential risk of losing key staff and with it their knowledge and expertise, which will be critical both in the present and the future. It also did not offer the same flexibility as the hosting arrangement in allowing the work on a new planning model to evolve. A very limited consideration of possible impacts undertaken on those at bands 8A to 8D within the board concluded that if transferred into the department, they were likely to be placed on marked time in terms of salary for a number of years. Counterparts in the same bands in the wider HSC would not have had this restriction. And this again would have amplified the potential risk of these staff seeking to leave current posts. A comprehensive analysis of the key differences in the pay scales and terms and conditions between the staff in the board and civil service pay scales and terms and conditions was not undertaken. To undertake such work would have been highly resource intensive, and it was ultimately considered unwarranted given the significance of the other reasons already outlined for the selection of the hosting option. In closing, Chair, I hope that members have found this briefing useful and that it helps to inform your scrutiny of the bill. We are making strides forward and receiving very positive feedback from stakeholders that this approach and direction for Northern Ireland is indeed the correct way forward. We're happy to take questions. Thank you.
Okay, thank you, Alan. So, firstly, from in relation to the I do note I do note the department's position as set out there. However, I will also, I think it's important to reference the fact that we did do a session here, an evidence session, with people who have been previously involved or currently involved with some of the LCGs, and they were expressing concern around the level of uncertainty as to what would replace it. I have also been contacted separately by other people who have experience and who work in the LCGs around a similar concern. And just taken, for example, and we are aware that the new system will include the trusts as part of the commissioning process. So, in recent meetings that I have done with GPs and things, they have expressed their concern around the rollout of the multidisciplinary teams. And there are clearly difficulties for everyone concerned in that staff are at a premium, those skilled staff who would fill those roles, and that the word that's used to describe it is that people are fishing out of the same pool. So my question would be, if we are in a new situation with the new ICS, where the trusts are part of the conversation, community groups are part of the conversation, GP and primary care, how will those differences be managed? What will the governance be in place? What will the systems of checks and balances in order to provide a fair discussion? So that element of it, would you agree, is very uncertain and is the basis of an awful lot of the concerns around stepping off the side of the platform without knowing where it is you're going to. So how would you address that issue? How will this be governed?
Yeah. Sorry, Chair, if I could come in, it's Martina here.
Go ahead, Martina.
Yeah. I think, Chair, I think it's one of the things that we do recognise and we do talk to people about is that, as Alan set out, this is an evolving model. So if we think about it at April 2022, what we want to have in place is the structures and those partnerships, but we'll still be undertaking the same commissioning process in that initial phase as we are now. And that's really because there's a lot of work to do in an integrated care system to actually make it work properly. And part of that is actually bringing those people together and actually working with them through the system. So they're part of this from the outset as to how we put in place the governance arrangements that's going to work with that, how we put in place the funding model, so how they are truly partners and have that equitable voice around the table. So a lot of the feedback we're getting is concern that the trusts are going to be there and the trusts are seen as a major power base. So how can we really change the culture within the health and social care itself? And then how do we make sure that we have that equity parity so that we have a framework in place so when there are, as you say, decisions that are contentious, that actually we have a framework that will allow those decisions to be made. But that's going to take time and we do understand that. But we do think we can have the structures in place for April. We can work with our commissioning teams that are in the board that will continue to work with the new ICS in terms of local intelligence and local planning. At the same time, we'll concurrently be going into each of those 5 areas, working with those groups and really putting in place the support structures that builds an effective partnership, that puts the frameworks around as to how decisions are made, because this cannot be we cannot really fall back to where we were in the past. So we cannot let this become a body where, as you say, there's maybe big players around the table who have the say. So we need to make sure that we build the space, the time, the development with everybody around the table, that this does become a partnership. And really the focus of that partnership always has to be, what is the outcome that we're trying to achieve? So it's back to this whole population-based approach. You know, in any decisions that are made, it has to always come back to its very, very simplest, you know, what is it that's best for the person who's actually at the centre of this? But I do understand your concerns. We do understand the feedback. You know, we are running these sessions at the minute. I suppose what we are asking is for people to, in some ways, maybe take a leap of faith with this, but we will have the structures in place. We will have those people. We will be working with them to get that local input and intelligence. We are hoping to go out now towards the end of this month in the strategic outcomes framework to really start to talk to people about what is it that matters to you. But we do know we will have to put partnership agreements in place. We will have decision-making frameworks. If a person on an ICS is not actually adhering to the partnership approaches, we need to think, well, what do we do in that respect? And we're doing a lot of learning at the minute, as I said before, from other systems, but we are working to make sure those structures are in place. And if we can, we will start to have those governance arrangements in place, because that we cannot actually devolve the funding to these bodies until we have a governance arrangement in place that can support that devolution, where we have very, very, very clear accountability, where we can actually have a funding system that gives the funding to that area and allows them to make those decisions, but where it's a simple funding system. If you think the minute is complex, we need to be quite clear about where the money's going and what it's been spent on, and what outcome and what it's delivering for the people of that area.
Okay, yeah, and I do want to say I do recognise the benefit of flexibility in terms of developing, and I think in common across the people who are currently involved in this, and community representatives and elected representatives and medical professionals, health professionals, everyone wants to see the system improve. You know, so I don't think anyone is afraid of change in that respect. It's just a question of, I suppose it would have been, in my opinion, it probably would have been better had the time been put into developing that model before the HSE bill was brought forward. That I suppose it seems a bit cart before the horse in that respect. But I do accept that you do acknowledge the concerns and you're aware of them. It's just how, along with the flexibility, how we get certainty and oversight in a way that delivers a better health system with real citizen involvement and community involvement.
Yeah, and I suppose, Chair, one of the things, you know, we are getting from people as well from the feedback is around that need for some kind of certainty. So as I say, at the minute we're saying this is a phased timeline because we do need to develop a new funding model. There's absolutely no doubt about that when it comes to funding health and social care. We need a new model that will underpin this system. And I think that that's some of the takeaways we're looking at the minute. So, you know, in terms of that timeline, to try and put a bit more certainty around that in terms of, well, this phase one, as I said, we'll have the area integrated partnership board structure in place at April, and what we'll work at now over the coming weeks is trying to put in more, as much as we can, indicative timeframes around the other parts so that people have that clarity about how we're moving through this journey. I suppose in terms of, you know, if we had the time again to do this, you know, I suppose you're right, absolutely. You know, we would have actually maybe been developing this at the same time the bill. When we took this on there, obviously we had been working on the bill. Unfortunately, we were all redeployed, as you'll know, to COVID for a significant time last year, which has impacted on our timeline. But I do take your point, you know, if you had the time again, and obviously we didn't have those other factors that had impacted against us, we would have had this far further developed down the line and been in a better position today with yourselves.
Okay, thank you. And then I suppose just briefly, so I'm going to move on to other members, but in relation to your response on the reporting to the committee, and I think this will be a huge job of work for this committee for the remainder of the term and the incoming committee, in terms of reporting, and you have said that that you're working on the, I can assure you, content official will continue to provide regular updates, and that an agreed schedule for the provision of written or oral briefing be established and agreed and finalised with the committee in due course. What is the time frame for that, Martina?
Well, what we want to do is just work with the clerk there, and we're more than happy to sit down with him after this and just put in a complete schedule of when we'll come and give you regular updates. If that is something that you're happy with, we're happy to work with Keith after this and make sure we schedule him in so you'll know at irregular intervals when we're coming. We are working, I suppose, Chair, just to say on on our timeline at the minute on implementation on our comms. So we're actually highlighting all key delivery points on this. So what we can do is do a schedule of briefings, and hopefully within that actually then identify when there's key sort of like decision points or documents or whatever, so we can make sure we bring them to you before we move forward. So for example, the strategic outcomes framework, we could probably come back to you in that in the next couple of weeks if you have time, obviously, but we can work with Keith and make sure we get a robust schedule in place.
Okay, and the committee also had indicated that there were certain things they felt were important that would be in these reports, including critically health inequalities and how commissioning is addressing those inequalities. Okay, listen, thank you for that, Martina. I'm going to go to members then. I'll go first to Carol and then I have Paula. That's the indications I have at present.
Thank you, Chair, and thank you to officials for your presentation. Martina, I suppose you touched on one of the points that I was going to raise about the strategic outcomes framework, which is really critical. So I look forward to an update on that. The concern that we have raised consistently is around the gap in services and workforce planning now before we move into a new model. So I just want to find out, where are our trade unions and staff side representatives and indeed our partners in the community and voluntary sector in this process? That's my first question, if you want to answer that now, and then I want to come back to other small points, Chair.
Yeah, in terms of community and voluntary, so up to, in those initial phases, what we have done is we had a representative of NICFA join our actual project board, and then within the work streams that worked on this draft framework, we had community and voluntary representatives from our sort of existing ICPs and LCGs. We have been working with the community and voluntary sector over the last number of weeks, really in terms of the framework itself. So we had a very specific consultation session there, which NICFA facilitated for us. And one of the things we're looking at the minute, and we're setting in place, is that the community and voluntary sector feel that they need, I suppose, a forum by which, first of all, we could look at how they directly input to the project. So how, it's okay for us to perhaps say, would such and such come and work on our work stream from the community and voluntary sector, but they said they in themselves obviously can't represent the sector. So what they wanted was a forum by where they could sort of report in and out about the work that we're taking on, gather views and feed that back into us. We also need a forum that's going to actually look at how is the community voluntary sector supported when they're actually part of these area integrated partnership boards. So kind of reflecting on that same issue that, if you have a couple of voluntary and community sector reps, 3, 4, whatever the number is around the table, how can they actually be supported to be at that table to represent the sector? So what do they need in the background, be that perhaps a forum that they can go to with the issues? So there is at the minute what's called the ICP Third Sector Forum that was established as part of the ICPs that are in place. That grew quite significantly over COVID. I'm not sure what the latest, I think there's maybe 99 voluntary community sector groups or something like that. We've spoken to them because that's a mechanism's already in place. So what they've said is that they're willing to widen the scope of that group should any other organisation want to join that's not involved in ICPs at the minute. And what we're now going to do is we're meeting with them in the next couple of weeks, and we're going to use that forum as a basis, so whereby they can actually directly input into the work streams, but also where we can start to look at, well, actually, when we're starting to set these up, what are the mechanisms you need to make sure that you can represent the voluntary community sector in your local area when you're actually sitting around that table, and what's the support, learning, development, and all of that comes along with that you'll need to do that. In terms of the trade unions, then we have been briefing them. I suppose I would say up to now it's probably been more sporadic. So what we're actually in terms of doing is making sure that we have a staff side forum very reflective of the one that is there for HSCB migration, set up that's very specific to future planning. So we have the staff side for migration, and we have been updating them about future planning. We have been meeting some of the trade unions separately about future planning, but we actually recognise now that this is a massive change that's going to impact across the system, and it actually needs to be wider than the staff side that we have set up at the minute. So we're just in the process of actually working with the trade unions to look to put the mechanism in place whereby then we have that regular engagement on the very detailed issues of these. Was there somebody else, Carol? Sorry.
No, that was it, Martina, on that point. Chair, can I just mention 2 other small points? So appreciate that update. It's just that the feedback that I've received over the summer is at variance with what you've given yourself. It's just that people are aware of things that may happen. They know there are discussions on, but they don't have a grasp of actually what's going to happen. And the concern that you've already mentioned is that when the The Health and Social Care Board closes on the 31st of March, and because the framework, even like a fully functioning ICS model, will not be in place on the 1st of April, that's your own briefing. I think that's what's grabbed the headlines. So I think you have a job of work to do in terms of working with your partners in trade unions, because there are a lot of staff out there who are unsure. The points I was going to raise were, Martina, the additional points was the workforce planning issue has been persistent and it will remain to be persistent. And the other issue is addressing health inequalities, who have also been persistent. The concern is that consultants have a greater say around those tables than what care in the community does, and particularly given the focus that's on social care at the minute, and in fact the privatisation of social care. I would like to know what discussions or what gaps are going to be filled to ensure that social care, and indeed care that's going to try and address, if not eradicate, some of the health inequalities, where and how is that going to be developed, with the same level of equity and equality around those tables, because that is, for me, one of the biggest neuralgic issues. And that's me, because that was the 2 points.
Thank you, Carol.
I suppose what I would say is we are getting that feedback. When we did the initial work at this and looked about that table of the area integrated partnership boards, we were trying, I suppose, to try and make sure we got the representation of everybody that we thought we should be around that table, but without making it too big and too burdensome. I think a lot of the feedback we're getting, and we have that in the last couple of sessions, is probably very akin to what you're saying about the balance. And if we are moving into this kind of, health inequalities, obviously outcomes based, and and very much what we predicate this on is actually the fact that our system as it's currently designed does not meet the needs of today's population. So, we do need to look at a different way of doing this. And a lot of that, as you say, is about what care can be provided to the community, what the prevention is. So I think it's something that we are going to have to consider very, very carefully over the next couple of weeks. And we're going to have to look back at that table again and see how that membership needs to work. Likewise, the chair of the group has been something that's came up as well. So that, again, is another thing we need to look at. I think there's been sort of feedback, as you probably, again, aligned to what you're saying, that it's very, very health heavy. But yet a lot of the determinants that impact on our health and well-being are outside the health remit, and there's so much expertise and, I suppose, knowledge in the community that can be done. So we are looking at that. I have engaged with the Social Care Council, and we need to continue to do that to see how we can best do this. Workforce planning, I think, something we are, and there's a new director of workforce planning in the department, and we've been engaging, because I think the whole point of this is population health planning, so it's planning for the needs of your population. So if you're planning your services to meet the needs of your population, then your workforce planning that should all come together. So, we are looking to see how we can really start to factor, because when you start to look at this, when you're looking at planning on population need, planning to improve outcomes, and those strategic outcomes are key as well. I would add that those outcomes are obviously beyond, that kind of health remit that we do gather in, that the responsibility of those groups is to that wider health outcome, that we do look at how we really start to do everything differently, and it really is so big and encompasses everything. That's the reason we're starting to filter even out ourselves into the likes of workforce planning, which I will be honest, at the initial outset wouldn't have necessarily thought, I must get workforce planning in, but absolutely you're right, it's key. If we have to plan for the future and plan for the needs of the population, then a workforce planning must be part of that. So we are picking those points up.
Thank you.
Thank you. Thank you. And going then to Paula Bradshaw. Go ahead, Paula, please.
Thank you, Chair, and thank you, panel, for the update this morning. My questioning is in relation to the expert input and also patient input. I know you've touched on it, but I'm just wondering, is there anything more you can say? I've had ongoing concerns about the removal of the board and the expertise and years of experience that they bring to this, external to the sort of public sector that works within the Department of Health. So I'm just wondering if you could talk a bit more around that, and whether the Patient Client Council will have an enhanced role going forward. And the second question is in relation to the deficiency, the inability of the Health and Social Care Board over the last 10 years to get an ME clinical lead specialist in place and a regional service. How will this new dispensation improve that situation? But wider than that, we know that there are a number of rare diseases that don't have a care pathway, and because the numbers are relatively low, then that we don't have the specialists, the clinicians, and the care pathway in place for those. How are rare diseases be picked up? And finally, the other point is in relation to engagement with independent contractors, and I'm talking, for example, around the community dentists, who at the minute are lobbying because they're very concerned about the future of the sector and the need for their members, the dentists, to move more into private work, because it's just not sustainable, the contractual arrangements they have at the minute with the Health and Social Care Board on behalf of the Department of Health. So it's really just around that wider engagement across so many sectors. Thanks very much.
Yeah, in relation to the PCC, so that we have engaged and have been part of this process from the outset. So their chief executive, as example, sits on our project board. That's the other group we're working with at the minute. So I think one of the things, same situation as the community and voluntary sector, that's been raised with us, is how do we ensure that we have that patient and carers, this is the other one that's come up, input into this process. So how do we get their input into this process? So how do we get their input into those work streams without obviously creating, burden? How do they represent views? Again, if they're around the table of the Area Integrated Partnership Board, how do we actually support them? We want them to be around those tables and be supported to be around that table, and not to feel that they're there just because the framework document says it should be there, if that makes sense. So what we've done is we've actually, it sounds like we're starting up, but we have another group set up. So this one's just starting as well. So we worked with the PCC, with the PPI leads. We've actually spoke to some of those service users that were involved in the likes of No More Silos, and they were very, I suppose, adamant that we have to be very, very clear for like the likes of patients and carers, how this will work for them. So we have a group that's just been established that Alan actually there is taken now, that we're going to work with them to work through this and actually come up with a model whereby they are able to input directly into our project, but also then we can support them part of the Area Integrated Partnership Boards. The professional, do you mean the professional staff of the board? Or did you mean?
No, I was talking about the Health and Social Care Board in terms of who the membership were, almost like that sort of committee. The
non-executive?
Yeah, the non-executive, sorry.
Yeah. So I suppose, the closure of the board, the transfer of the responsibility to the department does mean it's subject to departmental governance arrangements, and the department board, as you'll know, also has those kind of non-executive members. I think one of the things we'll probably need to look at as the Area Integrated Partnership Boards develop, and as the ICS model develops, is something that's being brought in is perhaps that need for independent chairs. But that's something that we need to work our way through at the minute, and that's what we're going to look at as part of this process. We've seen it happening in England recently. I don't know if you're following the ICS journey over there, where they've actually moved to put independent chairs in, so that's part of our consideration moving forward. I think it'll be very, very important when we do develop a funding model that will actually allow devolution of funding to those areas, that we have that kind of governance arrangements put in place around that. So that, again, is all part of this journey. In the first instance, as we said, we won't be having that devolution of funding until we can build that model, but I think it's definitely a key consideration for us going forward. I think the other thing we recognise at the minute is also that need for that regional planning. So that regional planning of specialist services, like you mentioned, and what can we do to improve on that? So what we've started working on at the minute is actually looking at, I suppose the basis of the area integrated care systems is that, in as far as possible, you should allow the local areas to plan as much as you can, but there'll always be those instances. So what we're looking at is, what do we need to put in place at a regional level to make sure that there's those services, such as the ones that you mentioned, that we have plans in place to make sure that we can actually provide the care that's needed for those. But in that space too, we don't want this to be a group completely removed from the local areas. So we're actually looking at how we can set up like a regional forum that will actually have responsibility for delivering in those, but which the areas come in on. Because a lot of the aftercare needs to be delivered close to home, so we're really trying to pull it all together at the minute. That's work we've just started again, but again, that can all form part of our briefings to use as we move our way through this process. And the independent, sorry.
Before you move on to independent contractors, I suppose you're right in the sense that the carers also need to have an input into this process, because where you have rare diseases and because of the complexity in many cases of the patient's circumstances, and their carers, that's 24 hours, and they just don't have the time to make sure that they actually attend, or even if it's virtually, get involved. And I'd be concerned there where if there's these area groups that they probably aren't even aware. I'm not aware of the vast majority of their rare diseases, but I'm just concerned that we would be reliant on people who are already very stretched in terms of their domestic pastoral responsibilities at home. So I think that's the concern I have. But no, as long as it's noted, I'm happy for you to move on to the last issue, Race. Thank you.
Yeah, just to note, we had an engagement session last Friday, and there was actually a number of carers on that, and we are picking up, and that's where it really came to the fore for them, because they were saying, don't rely on voluntary and community to represent us, because we're not always engaged, as you said, particularly if it's something rare, because you could be actually caring for somebody and in a respect, I suppose, quite isolated in giving that. And as you said, you're constantly, your time's taken up. So it's become a key point for us, and something that we are looking at the minute, how we make sure that those carers are supported. The question about the independent contractors, what has been raised, I suppose, particularly around the dentists, and I suppose in terms of the membership of the table, you will have noted that they weren't around that table in its initial iteration. And I think that wasn't, I suppose, in any way to say they wouldn't be. I think part of the consideration by the work stream when they were looking at that was they were trying to put a core that would need to be there every week. But actually, when you are talking about population health and prevention, oral health is a key aspect. So they were thinking we would bring them on as and when, but we take the point that actually is coming out again, and it has come through the dentists themselves about the key role they play, and particularly the independent sector. So that's the other piece that we are having to pick up on at the minute and work through. But hopefully we get a schedule of updates in, we can actually work through this and obviously take your feedback as we move through the process.
Yeah, thanks very much, very helpful, thank you.
Thanks.
Yeah, thank you. And actually, just picking up on Paula's point there, and on your response, Martina, I suppose we are acutely aware of the difficulties within dentistry and the huge inequalities that we have here in the north. And I suppose the key thing for us is that while you say dentists would be brought on as and when needed, if they're not in the room, you don't know what it is you don't know. That's the problem, and that's why, and as far as possible, all of these professions and expertise and knowledge needs to be in the room. The other thing, I suppose, that does strike me in relation to that conversation is around what are referred to as rare cancers, and yet half of all the deaths here, I think, in the north are actually from what are termed rare cancers. So it is a complex situation, and therefore hugely important that we get it right. So I just want to check if we have any other indications. I don't think so from members. We can, so I think thank you very much to our panel for presenting the evidence, for dealing with the question and answers, and for presenting the written response, which we're going now to consider as well. In terms of, and I know you had said there earlier, Martina, about a leap of faith, and I think we have got a clear sense. I feel we have got a clear sense of genuine will to build and develop a better system here across the board from yourselves and that. But I suppose our concern emanates from the size and scale and complexity and just the huge behemoth that health is, and that events and inertia are things, inertia, large organisations tend towards inertia, and that is the concern more than faith. It's about practicality and ensuring that there is that oversight. But listen, we will continue our consideration of this, but I'd like to thank you and wish you each of you all the very best of luck in the time ahead. Thank you.
Thank you, Chair.
Thank you, Chair.
Thank you. Okay, members, we will then now move into closed session to continue the committee's deliberations on the bill.
Signed. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound.
Okay, thank you, members. So we are back in public session, and I will ask the clerk then to go through what the committee has agreed in relation to our consideration on the HSC bill.
Thank you, Chair. Just the committee has agreed that we would get in contact with the OLC to discuss what options were considered when drafting the legislation, to see if that included an option in relation to continuation of LCGs. Also to consider possible amendments in relation to reporting, and in relation to Clause 4 and secondary legislation. So that's what, and we would have an additional meeting, if required, next week to consider any response from the department.
Okay, thank you. So members, then just members are agreed with all of that. Yeah, those course of action. Thank you. Members, due to the recall of the Assembly today, then we have rescheduled consideration of some of the SRs. If we have time today, we will cover some, but that's looking very unlikely at this stage. I propose, therefore, that we move. I want to check, Clerk, do we still need to take 22, 23, 24, or can we go to 25?
We'll go straight on to 26 and the correspondence, yes.
Yeah, 26 with the organ.
Yep.
So, members, with your consent, members, I think we should look at moving the correspondence to be agreed by email with members. So, if members are content, that will allow us to move on to the soft opt-out, the organ and tissue donation consideration.
Yeah, and sure, Chair, if there's any issues even within the correspondence people want to bring up, they can do it by email.
Yeah. Members content with that?
Is that okay?
Great. Yeah. Yep, thank you, members. So we will then move to item 26, which is the organ and tissue donation deemed consent bill briefing today from the Department of Health. So we will have an attendance here on, I think it's on, they're on video, Clerk, yes. Is that correct? Yeah. So we're expecting, just give me a second, Mr. Ryan Wilson, who's Director of Secondary Care within the Department of Health. Are you there, Ryan, and can you hear us okay?
Ryan's there, yeah, we have Ian.
Okay. I'll check then, do we have Ian Plunkett, who is head of the organ donation bill team? Ian, are you there, and can you hear us okay?
Yes, I can hear you okay.
Okay, and Ian, would you be able to proceed, if we don't have Ryan on the line, are you able to proceed with the briefing?
Ryan was to make an initial statement on this. I don't have a copy. I think he's trying to get online by phone.
Okay, we'll give it a minute. We'll give it a minute in session to see if we can get him on the line, and if necessary then we might suspend, but for now I'll continue on because broadcasting advice is sometimes easier to address those issues when we remain in session.
I want to cover the Fort Work programme just, and I can advise members just on the Fort Work programme. I will try and get... Yep.
So yes, go ahead then, Clerk. And so we'll move to Forward Work programme members, and Clerk will give us a briefing on an outline of the Forward Work programme.
Thanks, Chair. It's just to outline the next couple of weeks for members. Next week we have a briefing on the Autism Bill, which is the private members' bill sponsored by PAM. So there'll be an evidence session on that next week. We also have the first evidence session on the Adoption Bill. So the Adoption Bill is, I think it's 160 clauses. So I've split the briefing into two. The first one's going to be on the adoption process, and then the second briefing the following week is on the children's services. So next week we have the Adoption Bill, Part 1. We also then have the SRs that were due to be considered today. So they'll be on for next week. And again, we'll have a session scheduled for the Health and Social Care Bill. Then Thursday the 23rd, it's the Adoption Bill, Part 2. And then again, consideration of the Health and Social Care Bill. And there might be a possibility of another briefing in there as well. Then Thursday the 30th of September, we've got the Ministerial Briefing. And I know members have said about timing of that, and so we can certainly consider whether members will want even meet a wee bit earlier to allow a bit more time as well. And I'll check with members whether they'd be content with that. And then also on the 30th of September, we have October monitoring scheduled from the department. So, and again, we've bits and pieces on the Health and Social Care Bill and probably the severe fetal impairment bill as well for the possibly the 23rd or 30th. So that's certainly the next few weeks anyway.
Okay. Members content with that outline? Content. Yeah, thank you. Do we have Ryan?
I think that's the withheld. Yeah.
Yeah. Okay, so I'll go back then just to check that we do have Mr. Ryan Wilson, who's Director of Secondary Care within the Department of Health. Ryan, can you hear us okay?
Yes, Chair, I do, and thank you. Sorry, I wasn't able to join by video, so I've used the phone alternative.
Okay, your camera is off at the minute. I'm not sure if that's by necessity or
joined by phone.
So it's joined by phone, yes, okay. So listen, that's okay. We're hearing you clearly enough there, Ryan. So do you want to go ahead with your briefing, Ryan, then we'll move to members' questions?
Yes, thank you, Chair, and good morning, and thank you to the committee members for the opportunity to brief you this morning about the organ and tissue donation deemed consent bill. I'm Ryan Wilson, and I'm the Director of Secondary Care in the Department of Health. My team has policy responsibility over organ donation and transplantation, and I'm joined by my colleague Ian Plunkett, who is the bill team manager for this piece of legislation. So we met with many of the members of the Health Committee at an event hosted by the British Heart Foundation in January this year as part of our public consultation. And we're very grateful, after a very positive consultation process, to be here today with a draft bill ahead of the second stage debate on the 20th of September. So in that meeting in January, we discussed that there were very tight timescales ahead in order to have this bill enacted within the remainder of the current mandate. And for that reason, we welcomed the decision by the Health Committee to open its call for evidence over the summer recess, as this makes things much more achievable in the months ahead and has permitted us to do some detailed planning and engagement over that period as well. So a briefing paper has been shared with members. We apologise if it has been received late, but I'll go through some of the main points and then we'll be happy to take any questions about it. The donation of organs and tissues after death already helps to save and improve many lives in Northern Ireland every year. One donor can transform the lives of up to 9 people. And the main objective of this bill is to increase the current rate of consent in the small number of cases in which it is clinically possible for organ donation to proceed after a person's death. Doing so will increase the overall number of donors and ultimately the number of life-saving organs available for transplantation. So in order to set that in context, I have a few key figures to run through. Only 1% of us will die in circumstances where organ donation will be clinically possible. That is in hospital with intensive care or life support available, and that's generally someone for whom intensive care has no prospect of bringing about recovery. In general numbers terms, the UK-wide population is around 67 million people. There are just over 600,000 deaths on average per year, and out of that, only around 7,000 people of those deaths are potential organ donors. So it's a very small number, and an even smaller number then goes on to actually become a donor. So with this bill, as with deemed consent systems in neighbouring countries, a change in the law will not increase the donor pool. Rather, what we're talking about is opportunities to maximise the donation opportunities by increasing the consent rate from within that very small pool. Last year in Northern Ireland, there were 51 deceased donors, resulting in 113 transplants throughout the UK. In total, 87 Northern Ireland residents received transplants. Around 115 people in Northern Ireland are on the transplant waiting list, and every year around 10 to 15 people in Northern Ireland die whilst waiting on an organ transplant. So whilst we do very well in our consent rates generally, and we have very positive attitudes and behaviours in this country around organ donation, the demand for transplanted organs continues to outstrip the supply. 49% of our population have now joined the NHS organ donor register, and that's a steady increase from 30% since 2013. Many more than this, which is consistently around 90% of our population, say that they support organ donation. But in spite of this, around a quarter or a third of families can decide not to proceed with donation when faced with this decision at a very difficult time. And in Northern Ireland and in other UK regions until recently, the consent rate has remained at around 2/3 of potential donors. So this overall strategic aim here is to achieve a sustained world-class consent rate of 80% or higher year on year. So turning to the consent system that we currently have in place in Northern Ireland, we have an opt-in framework for consent for organ donation to proceed after a person's death. That means that donation will only ever proceed if a person had given their express consent for organ donation during their lifetime, usually by signing up to the organ donor register, and or the person's family supports the donation proceeding after death. In the absence of a decision being recorded on the organ donor register, or the family are unaware of their loved one's donation intentions, they are asked to make a decision on their behalf. The effect of the proposed change within this bill will be to shift the focus of the donation conversation, which is conducted with families at the end of life by expert NHS specialist nurses, to establish the known decisions of their loved one. Every other part of the end-of-life care pathway will remain unchanged and will be conducted in line with current clinical and professional standards. So the current statutory framework for consent will require new primary legislation in the form of this bill to change the current system in Northern Ireland, in which people can choose to opt in or opt out on the ODR, to a new statutory opt-out system in which consent is deemed or presumed, except in certain exempt circumstances, or if a person has made a decision to opt out during their lifetime. This is often referred to as deemed consent. So turning to the bill itself, the legislation which underpins organ donation and transplantation in England, Wales and Northern Ireland is the Human Tissue Act of 2004, which covers all aspects of consent around both living and deceased organ donation. We consulted the public on policy proposals about how deemed consent could be introduced, and we based this on the systems that are in place now in Wales, England and Scotland. The explanatory and financial memorandum, which members will have received, describes how Clause 3 of the draft bill would give effect to those policy proposals, and the policy proposals are as follows. It will be considered that everyone living in Northern Ireland agrees to donate their organs when they die, unless they have confirmed otherwise by opting out on the ODR, or otherwise making their decision known, or they are from one of the excluded groups. Individuals will still have the choice about whether or not they want to become a donor. Families will continue to play an important role in the consent process in all cases. However, whilst the nature of the end-of-life discussion with families would change, the family will always be asked about the last known organ donation decision of their loved one to ensure that it is still accurate. Decisions based on faith and belief will continue to be respected. Deemed consent should not be applied in the case of donation of organs for research purposes, for which there is a separate process already covered by the Human Tissue Act. And deemed consent should not be applied in the case of novel and rare types of transplants, for example, face, limbs, genitals. That is, that it will apply only in respect of human organs which are normally considered for transplantation, which is hearts, lungs, livers, kidneys, pancreas and small bowel, as well as tissue including heart valves, corneas and bone. So moving to the groups that are proposed to be exempt from the deemed consent provisions, that includes children and young people who are under the age of 18, and they can still obviously become organ donors, but their consent just would not be deemed under this system. Adults who lack capacity to understand the new system, people whose identity is unknown, and people who are not ordinarily resident in Northern Ireland, and that includes tourists, cross-border workers, people who are temporarily resident in Northern Ireland, including students, armed forces personnel, and people who work on placements. So in technical terms, the bill achieves these changes by proposing amendments to the relevant sections of the Human Tissue Act of 2004. Clause 3 of the draft bill also seeks to amend sections 15 and 16 of the Health Miscellaneous Provisions Act, Northern Ireland 2016. And members may recall that that act was introduced by the Assembly in 2016 after the Health Committee had considered a private member's bill to introduce deemed consent at that time. The Miscellaneous Provisions Act introduced a statutory duty on the department to promote and report on organ donation, and that work has been developed now to a point where we have a very comprehensive communications programme which runs year round, and I hope that we will have the opportunity to speak about it with PHA, Public Health Agency colleagues later on in the bill process. And that work will continue regardless of whatever the Assembly decides in relation to this deemed consent bill. However, what this bill proposes is effectively an extension to that existing duty to promote, and specifically to promote and inform the public about deemed consent and about their individual right to opt in or opt out of deemed consent. And this is a very important provision which we have included on clinical advice, as it ensures that in future years there will always be information given to the public and to future generations about what the law says, and that will simply be embedded within our existing rolling communications programme. So in terms of developments since the committee last considered this issue in 2015-16, it's worth looking at what has happened in those intervening 5 years. At that time, Wales was just becoming the first region of the UK to implement a system of deemed consent, which came into effect from December 2015. And it was felt at that time that Northern Ireland should observe developments there for at least several years. The Welsh consent rate has increased in that period from 58% in 2015 to 70.7% in 2020. Although the impact was not immediate, and it did take several years to begin to take effect following an extensive media promotion and an information campaign by the Welsh Government. In England, a new opt-out system came into effect from the 20th of May 2020, and that is now firmly embedded and is working well. However, it is probably too soon to analyse any long-term impact on the consent rates. And Scotland's opt-out system came into effect from the 26th of March 2021. Moreover, there is an increasing level of acceptance, understanding and support amongst the clinical community and the public for deemed consent. And whilst it wouldn't be appropriate for us as officials to speak on clinicians' behalf, we trust that the committee will want to hear from those clinicians and from professional bodies in due course. However, we can say that since our consultation, we have had extensive engagement with the clinical community, and our view is that the overall context has shifted in that time period. This is likely because of the Welsh system has now reached a level of maturity which provides assurance, and also the successful implementation of deemed consent systems in England and Scotland. There has also been a notable increase in public support and understanding, and this is reflected in the positive responses that we have received to our public consultation. The credit for that, I think, needs to go to local campaigns by people like Dahi McGowan, Lucia Quinney-Mee, Joanne Dobson and their families, and many others who have raised public awareness and understanding about organ donation to a level where we feel there is now a very strong base of support and public confidence in the concept of deemed consent. So just looking briefly at some of the recent consent rates across the UK nations, in 2019-20, Northern Ireland's consent rate, this is relating to potential donors where there is a consent conversation taking place with families. Northern Ireland's consent rate was at 64%, and that's been fairly consistent across recent years. England was at 68.3%, Scotland 64.8%, and Wales, as I mentioned before, at 70.7%. We have included in our briefing paper also the consent rates for the most recent published year, 2020-21. But it should be noted that these figures are not directly comparable to previous years, and that's due mainly to the impact of COVID-19. So whilst we have seen a very positive consent rate in Northern Ireland at 79%, we have to put that in context, and it's important to note that across the UK there was a 25% fall in the total number of deceased organ donors in that year, and a 28% decrease in the total number of organs donated. So just to put that in context, we have to remember that Northern Ireland has a relatively small population and a relatively small donor pool, so the consent rate is prone to relatively high peaks and low troughs from year to year. So we welcome that high consent rate, but we feel that the change in legislation that's being proposed is a way to grow and sustain that in the long term. Just briefly on implementation, we are working towards royal assent of this bill, subject to the Assembly and the Committee's approval by the end of this mandate, so aiming for royal assent by around April next year. And we would envisage that approximately 1 year of implementation planning would be required thereafter. And the reason for that is several pieces of work that would then need to be undertaken following approval by the Assembly. Legislation will be required to be laid at Westminster under negative resolution procedures to amend relevant sections of the Human Tissue Act 2004. In addition, the Human Tissue Act has also created the Human Tissue Authority as the UK regulator for overseeing the legal consent requirements, and it provides advice and guidance to professionals via codes of practice. So it is likely that a new code of practice will need to be developed by the Human Tissue Authority for changes in Northern Ireland, as was the case in Wales and England. And there will be a need for a period of training of relevant clinicians and healthcare professionals for those changes and for those codes of practice. And finally, there will be a need following enactment for a period of major public engagement. And as I said previously, there's a lot of detailed planning underway for how we would add that and embed that within the existing communications. As I said, we will welcome the opportunity to provide more detail on that through the questions and answers or later on in the process. But in the interest of time, Chair, I think we can pause there and to take any questions from members.
Yeah, thank you, and that's been very useful. So I suppose the only one from me at this point in time, just in the interest of brevity, because we are under some time pressure, is around the public consultation, and I'm very pleased to see you'd said there that there's clearly increased public support, and I also want to acknowledge your comments and agree with your comments around all those who have been campaigning. And Deputy Chair and myself met with Dahi McGowan and his family, one of the first meetings we did, a very early meeting, and I have to say I'm delighted. Well, first of all, to acknowledge and praise their campaign and others, as you have mentioned, there have been campaigning for many years, but I'm delighted now to be in a position where we are now sitting in Health Committee considering this, so that's great and great progress. In relation to the consultation, which was finalised in February, when is that going to be published?
Very soon, Chair, and apologies on our behalf. That's just a piece of work that needs to be cleared through the department for publication. But we've given some summary in the briefing paper just about the high level outcome from that. It was a really well supported public consultation. We had almost 2,000 responses to it from a really wide range of the public. Quite a lot of healthcare professionals, over 100 individuals who were healthcare professionals, and 15 responses from health professional groups and organisations. Yeah,
I've been through the highlights, and that is welcome. That's a welcome indication. But what I'm saying is, and especially because of the high public interest and public interaction, I think it's hugely important that is published as soon. And when you say very soon, what do you mean? Like, are we talking about before the end of this month?
I would hope so. Yeah.
Okay. So I'll go to members then. I'll go first of all to Deputy Chair Pam Cameron, and then I have Ciara and Jerry. So go ahead, Pam.
Thank you, Chair, and thank you, Ryan and team, for your presence at committee to brief us on this, which obviously it's a very sensitive and often contested issue as well. But I do welcome we're talking about it this morning, and as the Chair alluded to, 2020, Migraine was one of the first meetings we did as Chair and Deputy Chair together, and it's good to see us actually getting to the stage where we're looking at this issue now. And I do welcome the fact that the First Minister did give approval for the bill to proceed by way of urgent procedure to the Assembly after the Donate for Dahi campaign gained traction. That's very welcome. And I also want to put on record as well the work that Joanne Dobson, previous MLA, did on this Health Committee in the past, and I think at that stage we probably weren't there in terms of awareness, and I think that a lot of good work has been done since then, so that's also very welcome. And obviously the awareness is probably the most important part of this subject, and making sure people are fully aware of the consequences and what the issues are and the opportunities as well arising from it. So I wanted to just basically ask in and around if you could just give us briefly how the soft opt-out system has impacted rates of consent for organ donation in other jurisdictions, and could you tell us about the proposed exemptions and tell us how they compare with the provision in other regions as well? I mean, one particular concern would be, the definition of long-standing friend. How would that be agreed? So if you could just tell us a wee bit more on that, that'd be great.
Thank you. Go ahead, Ryan.
Thank you. So just to take those points in order, firstly, I mean, the awareness around the provisions of this bill and the change is really a big part of our planning, which is underway. The aim will be to really make sure that message goes out across multiple channels to multiple audiences, and really to try and reach every member of the population here to make them aware of what those changes are and what their options are. And as I said, that will be a continual responsibility that we'll put into the annual programme every year. So there's already good levels of awareness and support for organ donation, but just in relation to the individual choices here, that will be really important to get across. We have been working with NHS Blood and Transplant, which is the organisation that coordinates and oversees donation and transplantation across the UK. They have overseen this in the other regions, and they bring a lot of experience into this, a lot of insights about public knowledge and public behaviour, and where those communications can really be effective. So we're factoring those in to our plans. In terms of the rates of consent, really, there are many countries around the world with deemed consent, but have different health systems and different histories. So we try in drawing comparisons to look at nations that are culturally similar. Wales gives us the best example really because of the maturity of deemed consent there. Since it came into effect in 2015, they're now almost 6 years into that. That has had a steady increase to the point where the consent is now over 70%, and that has been hand in hand with public information on an ongoing basis. So I think it's been acknowledged that it takes time to slowly and steadily build that cultural change. As I said, we have included some of the figures from the last full year, but I would take those with a pinch of salt, really, just given the impact of COVID right across the whole system. So there's been good consent in Northern Ireland, but there's I think we need to look at the history of donation and consent rates to see that it has been fairly static at around about 2/3 or 64% for a number of years.
Sorry, Ryan, for interrupting, but just, I suppose, can I suggest just in general, given time constraints on them, if there are more detailed information that maybe would be easier sent in writing, maybe just forward that on in writing to us. So if I could just ask members and the panel to be as brief as possible for today's session. Mm-hmm. Yeah, thank you. Sorry, Ryan, go ahead.
Sorry, just I'll try to be brief then. In relation to the proposed exemptions, the provisions of this bill are more or less identical to the system that are in place in Wales and England and Scotland. We've borrowed quite a lot from the English bill, which is short and sweet, and really you'll see from the text of the draft bill, it really just makes those changes to the underlying human tissue legislation. The exemptions around people who are under 18, people who are not ordinarily residents, people who lack mental capacity are the same and would operate in the same way. So those changes to the human tissue codes of practice will be written into the Northern Ireland codes in a similar way. So there'd be consistency in how those are applied. In relation to the long-standing friend, the Human Tissue Act contains a sort of long-standing hierarchy of qualifying relationships, which allows clinicians and specialist nurses to look at who the deceased person knows or is close to or is likely to have confided in around these decisions. So it's acknowledged that isn't always the nuclear family, and that's the reason why there's a hierarchy there, and quite often a long-standing friend, it can be fairly loosely applied. It's a question within that specialist conversation with families where the specialist nurses are qualified to establish whether these relationships and known decisions are effectively well known and can be relied upon for the decision to go ahead. But I mean, if there's any doubt around that, there won't be any donation of organs that would take place. So hopefully that's covered those points. And yes, happy to send more detail in writing if it would be helpful.
Thank you. So I'm going then to Ciara, Jerry, and then Paula. We have a maximum 10 minutes there because we do need to cover a few items just before we close the meeting down. And also members can, I'm sure, forward on to the clerk any questions might arise for a written response, should that be the case. So I'll go to Ciara. Go ahead, Ciara, please.
Thank you, Chair, and thank you both, Ian and Ryan, for being here this morning. Forgive me if my sound is a bit touch and go. I've had a few technical issues this morning. I just have one question in the interest of time, and it's around education and under 18s. I'm just wondering, is there more we could be doing, or is the Department of Health liaising with the Department of Education on kind of promoting the idea of donation in schools? Because I would hate to think there's kind of a missed opportunity there, talking about consent and talking about donation. So just if I could get an update on that would be very helpful. Thank you.
Yes, very, very briefly, and this may be one we could write to you on because there's a lot going on in that space. I referred to the programme of communications, which is now well developed and runs effectively all year round. A big part of that is looking at different age groups where cultural change can really be effectively embedded. We have had a regional coordinator manager of organ donation campaigns in place for over a year now, who's based in the Public Health Agency, and that has really made a huge difference, because there's always been good work going on around Northern Ireland. It has never been done in a really regionally coordinated way, and that is now happening. There's been good engagement with the Department of Education, and there's been some leaders from various schools across the region who have stepped up and really taken the reins on this and developed really good materials for different age groups, which teachers can freely download. So it will take an effort to really spread that right across the region, but that work is well underway, and if we get a chance to come back to the committee during the formal committee stage, we can perhaps spend a bit more time just going into the detail of the work that's already underway. And as I say, the information around the provision of this bill will be embedded within those programmes.
Okay.
Thank you.
Thank you, Cara. Thank you, Cara, and thank you, Ryan. Jerry?
Thanks, Chair. I want to echo your comments about We Die and the campaigners, so to put that on record, Chair. 2 questions. You mentioned about identity unknown, people being exempt from the opt-in. Could you maybe expand upon that? Is that people who are undocumented, refugees or asylum seekers, or who is that? And then the increase in organ donation is obviously very welcome and important. And is the main opposition to it people who have strong religious views, or can that increase be increased further? Is there any modelling being done about is dispelling myths and encouraging more and more people to come forward, because that 20% jump is significant, and if we increase that further, it would be even better. Thanks.
Thank you. So just firstly, in relation to the exemptions from opt-in, sorry, Jerry, can you just remind me what the specific point of that question was?
Just your phrase was people whose identity is unknown. So I'm curious on what that is.
Okay, so the reason why those are exempt, donation of organs will not proceed in those cases, and there are rare occasions in which people can present. These cases take place in intensive care generally. Hospitals will make every effort, obviously, to identify a person, and we actually covered this question in an engagement session yesterday. If necessary, we'll phone the police and we'll try their best to get a relative or somebody who knows the deceased person, and that's just a standard part of the pathway. When it comes to an organ donation conversation, if there's nobody there to verify the identity of a person, then donation simply can't proceed, and there wouldn't be any change to that under this legislation. That's why that's just specified as an exemption. You asked about the main opposition and whether that's religious. We really haven't received anything that you would call opposition to this. There's interest, and we have obviously, I think religious and faith groups are interested to know what this means, but I think that they probably will want to respond to the committee's evidence call and have a chance to come and discuss that in more detail with you. But there hasn't been anything received by us by way of opposition to the provisions. I think generally any faith or community groups are supportive of anything that might improve the consent rate. And just in terms of dispelling myths around organ donation, that's already a really key part of all the messaging. It's threaded through every channel of communication. We try. There's, I think, in the public generally a good level of support for organ donation, and it's been helped by those campaigns. But beneath the surface, there's varying levels of understanding about the actual process, and just as I said at the start, the very small pool of people for whom organ donation may be a possibility. So around that, there can be myths, and we try already in our communications to provide clarity on that, and the education is a big part of it. So that, as I say, that will continue regardless as part of those communications, and we'll just continue to address those questions as they arise.
Thanks.
Thank you. And Paula.
Thank you, Chair. I just wanted total clarity on the deemed consent model as regards the under 18s. And I'm thinking more so the probably pre-teens who probably, wouldn't really even understand the information if they had in front of them. So what is the situation with children? Thank you.
So I think what we're getting at is the current system and whether that will change. So any under 18s can currently become donors. It's a decision that their family would take if in those unfortunate circumstances if somebody passes away at that age. But having said that, there is very good levels of understanding we know that through the Children and Young Persons Attitude surveys that organ donation is understood at a decent level. The reason why they would be exempt from the provisions of deemed consent, this is similar to the systems that are in place really across the UK. People at that age group can still become organ donors. The fact is just that it will remain a decision for their families. Hopefully that clarifies.
Okay, the second question, I think it might have been touched upon there, and that's around the LGBT community. We know in terms of, for example, in palliative care, there's still a lot of, in some families, and hopefully it's rapidly changing, but where there are same-sex couples and maybe the family maybe even aren't aware that the person is in that position, and they would probably be their closest relative to be able to provide that insight into their final wishes. Just wondering what you are doing to make provision in there for these circumstances where those conversations and that those relationships are maybe not known. Thank you.
Can I just clarify? Are you asking about the hierarchy of those relationships and who really would have a say, or who would have the?
Yes, certainly that, but also in terms of how that could be better facilitated and how the communication around this could be improved, so that where there possibly are sensitive conversations going forward for the clinicians, for example, where they're provided with guidance and support to navigate those situations, obviously in a highly sensitive grieving period. Thank you.
Okay, so I think, I can probably answer this in general terms, but the better opportunity might be when the committee goes into the formal scrutiny stage, because I think you will want to hear from the specialist nurses who have those conversations and the clinicians in intensive care. They are the ones with the experience of really all ranges of very difficult and very sensitive conversations with families and other relatives and loved ones. So I think they can give you a more detailed answer based on their experience. But the codes of practice really are the underlying guidance that help professionals in those scenarios. But I will take your point around the maybe the need for communications around that area to specific groups and see if they can be factored into the plans around public awareness on this.
Thank you, Chair.
Okay, thank you. Okay, thank you, Ryan and Ian, for your presentation here this morning, and thank you for the commitment to send on further information in relation to some of the questions, and also in relation to the publication of the consultation. So thank you for that, and that's wish you both all the best in the time ahead. Thank you. Okay, members. I think it would be useful, members, if we write to the Minister to request that the outcome of the consultation is published before the second stage of the bill. I think that's a key consultation, and it would be good to see the results of that published. Would members be content that we write to the Minister in that regard? Thank you. Agreed. Moving on then, members, and any other business? Do members have any other business? No, thank you. And then date, time and place. Oh, sorry, just to advise members, there has been a formal request now from the Education Committee for a joint meeting to be briefed by the Education Minister, the Health Minister and the Chief Medical Officer. So are members content that the clerk continues to make arrangements on our behalf for that meeting?
That's separate from our briefing with the Minister? Yeah.
Yes,
Yeah.
separate and additional joint meeting with the Education Committee. Okay.
Yeah, but do we not ask that the PHA are involved in that as well?
Yeah,
CMO and CSA.
I've put the request through for
Okay.
the Minister, CMO and PHA.
Okay.
Yeah. Okay. Okay, members content. So members then, our own next meeting, you'll be advised about when that meeting will take place. Our next scheduled Health Committee meeting is on Thursday 16th of September at 9:30 a.m. Okay, thank you members.
Thank you.
Good luck.
This is the Northern Ireland Assembly Senate Chamber Programme Sound.